I'm going to show you a little bit of what we can do with back pain, neck pain, a few of the interventional techniques that we can offer the patient, and I'm going to go over the management too, because it's something that we need to know to be able to offer this to patients. So these are my objectives for today. How to manage back pain, identify the techniques we can offer the patient, and the potential complications. So is it a problem? 80% of adults will have at least one episode in their lives of back pain. By the third decade of life, 50% will have one episode that will affect their daily activities. And despite the best management that you can offer these patients, up to 5% of them will progress to chronic pain and disability. So the numbers will be 86 million in the USA will suffer from chronic pain. 8 million are going to be completely disabilitated, so that's about 10% of that. And around 65,000 new cases are diagnosed every year. It's going to be the second cause of a physician consult, third cause of surgery, and the fifth cause of all hospitalizations. So what about sick leave? Well, it's 40% of patients that have an absence from work. It'll be because of back pain. So it's just second after the common cold. We're going to divide back pain in three categories according to the symptoms, to duration of symptoms. It's going to be less than 8 weeks, so that's going to be our acute phase. 8 weeks to 6 months, that's our subacute phase, and over 6 months, that will qualify the patient as a chronic back pain patient. Most of the patients, as you know, will recover from the initial episode within 8 weeks. That's the time it takes for if it's a small disc protrusion or a small disc herniation, that's the time it takes to get reabsorbed and just deal with that back pain. The North American Spine Society is going to define 8 weeks as the initial phase of treatment, and usually no surgery is approved by the insurance companies within those 8 weeks. The patients with symptoms that last over 6 months will have obviously a bad prognosis. So what are we going to try to do in those 8 weeks? We're going to use the pain as a function of pain and function as measures for severity and predict the treatment. We have to try to identify patients that require early surgery, and we're going to mention those symptoms, those patients in the next slide. We're going to identify the patients that have very important functional deficits that are going to require more aggressive treatment, and we're going to try to alleviate the symptoms so the patient can go to physical therapy, educate the patient, and identify factors that predispose to chronicity, like unreal expectations, depression, anxiety, multiple somatic complaints. So what should not go unnoticed? Any loss of reflexes, severe focal weakness, severe proximal weakness, Babinski sign, ankle clonus, hyperreflexia, loss of sphincter tone. So any neurological deficit that accompanies the pain, it's a sign that the patient may need early surgery and cannot wait 8 weeks. What are we going to do if the patient doesn't have any of these? Well, we're going to give analgesia. We're going to have special attention to help the patient continue working and to help the patient sleep. muscle relaxants. We can start physical therapy, and our analgesics should allow the patient to undergo physical therapy. That can be transcutaneous electric nerve stimulation, ultrasound, warm compress, massages, and in these first 0 to 8 weeks, the interventional techniques are part of the treatment. Physical therapy, massages have been proven to help. Stretching does not help. Then the second phase, from 8 weeks to 6 months, if the patient still complains of pain, we're going to need to reevaluate, see if we have the right diagnosis or we're missing something. Usually, this is when you ask for an MRI. I know this would be the ideal world, and usually you get an MRI as soon as the patient complains of back pain. But the ideal management would be if the patient does not have any neurological deficit, the MRI should not be ordered until after 8 weeks if the patient continues with pain. But let's say we didn't have an MRI, but this time the first 8 weeks maybe it is managed by the primary care physician, and then after that, if the patient still complains, then it gets referred to the orthopedics or neurosurgery. So they get an MRI. The disc and the facet are going to be the most common triggers of pain in this period. We're going to continue with NSAIDs, maybe add opioids to the patient. We can add neuromodulators like gabapentin, amitriptyline. Maybe you've heard of Neurontin. A lot of these patients are on Neurontin. That's a neuromodulator. This is when surgery comes into place. If there is if we can find a reason for the pain, and interventional techniques are still, we can still offer some of them to these patients. And then patients that have pain over 6 months, it's a very bad prognosis. It's really, that patient is not going to get better. By this time, they've usually had multiple surgeries and interventional procedures. Anyone with pain that lasts over 6 months obviously is going to have a big emotional component, and that's just a cycle that does not allow them to get better. They're going to be put on long-term opioids or be offered neurostimulation. So what can we offer to these patients? We can start with epidural steroid injections. We can offer facet blocks, medial branch blocks, sacroiliac blocks, C1, C2 blocks. We have nucleolysis and discography that is no longer used in the U.S., so I'm going to skip that. But discography could have some role in a few patients that have viscogenic pain. Vertebroplasty and kyphoplasty, also not going to talk about that. I'm not going to talk about that because that's a different kind of pain. You have an acute fracture, it's different. And finally, spinal cord stimulators. We can also offer that to the patient. So we'll start with the epidural steroid injections. You've seen me or heard me do these ESIs. That's an epidural steroid injection. It's indicated in patients with radicular pain that does not improve with the conservative management. Usually the patient will have a disc herniation, a canal stenosis, foraminal stenosis, or discogenic radiculopathy. There are 3 accesses that we can use to inject in the epidural space. We can go through in between the laminas, so that's the translaminar approach, transforaminal in the neuroforamen, or caudal, that's transsacral. What do we need? We just need a needle, 25 to 20 gauge, a spinal or toy needle, contrast, local anesthetic, steroid, and very importantly, fluoroscopy. One of the disadvantages, I guess I'll go over that later, but one of the disadvantages of the ESIs, and that's only for the translaminar approach, is that they can be done blindly in the office. And but that would be equivalent to a sham procedure, because you don't know what level you're injecting, you don't know where the medication is spreading, and studies have shown that blind ESIs do not help the patient. Needle navigation is very important whenever we're doing any of these. Spinal needles have a bevel, cutting edge, and a bevel, and small spinal needles from 25 to 20 gauge, they're going to tend to deviate away from the bevel. And we can use that to our advantage by the needles, have a marker, like you see here. That little notch will point to the side of the bevel. When we advance, and you can use this for LPs too. So when you're advancing that small needle, it won't advance straight down. It will start to deviate away from the bevel. We can rotate that if we want to go caudally or cephalad or left or right. We can rotate the needle with this marker, and the needle will tend to go opposite to where the marker is. So if you're doing an LP and you have your marker down and then you hit bone, you're hitting the lamina, you're right there, what you can do is just turn that little notch up. That'll turn your bevel, and it'll deviate down a little bit and maybe help you go into the intrathecal space for LPs. And this navigation allows us to do this, and we can navigate with long needles. And for example, this is an L5S1 disc axis. The L5S1 was low, the iliac bones were high. So we started up here, we were able to navigate the needle down and then up and into the disc space this was a nuchal lysis. It wasn't done here. This was my dad, so that's why you see the same name. The translaminar approach, we can do it at the cervical level, dorsal level, lumbar level. It's very simple, very low complication rate. Disadvantage, you can have these blind injections done by everyone, everywhere. It has a dilutional effect because you need to inject, you need a lot of injectate to cover the area. It does not reach the ventral space where the nerve roots are coming out. Post-surgery, patients with laminectomy, obviously you don't have an epidural space at that level, and you cannot do this translaminar approach. It's overused. This is the first thing everyone asks for, just an ESI. And the efficiency is questionable. You have reports that go from 20%, reports that go from 90%. We usually tell the patients that it's about 50 to 60%, and 50% is like the flip of a coin. So they can either do well or don't. I mean, we don't know. The epidural pattern, when we inject contrast, the contrast will be unilateral, bilateral. It's vacuolated, heterogeneous, diffuse. It has no margin, and it's asymmetric. So you see here, which one would be the epidural pattern? Anyone? Right side. And this one here? So this one would be intrathecal. So this needle, and this is cervical. So this needle went a little too far in. Contrast was injected, and you see the intrathecal spread is it has margins, is very homogeneous, and you can actually see the nerve root sleeves coming out. So and you can see the spinal cord in the middle. So epidural pattern, backwallated, irregular, no margins. In this case is bilateral. This is the technique. So if you see the syringe here, we're pushing the envelopes of the syringe. We're advancing the needle until we see that loss of resistance. This is called the loss of resistance technique. When you're in the soft tissues of the paraspinal muscles, you cannot push that air down. As soon as you traverse the ligamentum flavum, you'll feel that loss of resistance, and you can see here advancing at the same time, and then it'll just pop down there. We don't advance the needle there anymore. We position the patient prone. We clean the area of interest. We just put a small drape or towels and do what we did. We select the level under fluoroscopy. What's the steroid that we inject? You can use any steroid. These are equivalent doses. Methylprednisolone, 40 milligrams, and this is the most widely used. Triamcinolone, betamethasone, dexamethasone. We use dexamethasone here, and just because this is a particulate steroid, this does not have particulates, and that is important when you have vascular uptake. If you're using a particulate steroid, if you have vascular uptake and you don't realize that, and you inject and it's arterial uptake, then you can have a stroke in that whatever that vessel is going. Liquid steroids with no particulates, it doesn't matter. You can inject them intravascularly. So that's what we use. We select our level. We want at the lumbar level or cervical level or spinous process in the middle. If a patient has scoliosis, it doesn't matter. We're going to focus on the image, not on the patient or how the C-arm is oriented. We just want our spinous process in the middle, and we want to try to open that interlaminar space as much as we can. You can see lamina here, lamina here. This is the L4, L5 level. Lamina, and this space is the one we want to use the most. I usually go straight in the middle. That'll give you a bilateral contrast spread. You can go parasagittal too if you want. If the patient has only unilateral pain, you can go a little bit more to the side, and you'll have more unilateral spread. There's a midline epidural raphe that is fenestrated, so you should have, even if you're on one side, you should have some spread going to the contralateral side. And we inject contrast, check for vascular uptake. On the translaminar approach, you won't have any arterial uptake. You may have some venous uptake, and you don't want to inject there because all your steroid is going to go to the venous space and it's not going to get concentrated there. There's no worries of any arterial stroke when you use the translaminar approach. On our lateral view, our contrast is going to be located in the back, and our needle is just going to be just slightly past the spinal laminar line. On the lateral view, you're going to have your spinous process, and where it meets with the lamina, you're going to have this line here, and that's where you have your ligamentum flavum, and your needle is just going to be past that. Not that important at the lumbar level, very important at the cervical level. Cervical level, again, we center our spinous process, we open that interlaminar space, put that needle in the middle. We use that down the barrel view. Once we have our needle down the barrel view, we just advance straight down. cervical level, it's a little bit more tricky. You want your lateral view. You want to make sure that your needle does not go past that spinal laminar line. I mean, just barely past the spinal laminar line, because you don't have any space there. The epidural space at the C6, C7 level is going to be about 2-3 millimeters, and then past that you're going to have spinal cord. You can see here your lateral view, tip of the needle just past spinal laminar line. You can see it better here. Spinal laminar line is this radiopaque line here. Backvolated diffuse pattern, and on the lateral view, I don't think you can see it well because I mean you have the shoulder there, but you have the needle and the spread of contrast in the posterior epidural space. That's your spinal laminar line, and that's where you want your needle. I always try to check an MRI T1 sagittal for any cervical translaminar approach. Basically, above the C5, C6 level, if you can see, you don't have any fat, you don't have any epidural fat. So it would be hard to keep your needle in the epidural space above C5, 6. Below C5, 6, you start to have some epidural fat, and it's safe to do them. So I don't do translaminars above C5, 6. If a patient has a nerve root that is involving any level above that, then we do transforaminal. The transforaminal approach, again, we can do it at any level. It can be diagnostic or therapeutic. If we do diagnostic, if we want to see if that nerve root is the one causing the pain, we only inject lidocaine. If we do a therapeutic injection, we inject lidocaine and we inject a steroid. It has better distribution with more concentration in the level of concern. You just need the same training. It has better efficacy than translaminar approach, with 70% of patients improved versus 30% of controls, and up to 50% of surgical candidates cancel surgery. Thing is, you need to have a level that is causing that pain to know, to do this transforaminal. That's why you can do a diagnostic first. Patient goes home. If that pain gets better with just lidocaine and the pain comes back, then you can do a therapeutic level. Most of our patients will have several levels, and you can do this at several levels too, but most of them will have several levels. At the lumbar level, we just need an oblique view, the Scottish dog view, and that's where we're gonna advance our needle to the inferior edge of the eye of the Scottish dog, right here. We're gonna touch that inferior edge of the pedicle, and then just slide the needle. Then we turn our C-arm to an AP view and just barely slide the needle below the pedicle. And we're going to have a little bit of fat there. We don't want to go anywhere medial to the middle of the pedicle, because then we're going to puncture that nerve root sleeve, and we're going to have some interthecal spread, and we can injure the nerve root. Once we're in that position, we inject contrast. Here is much more important to inject contrast than in the translaminar approach, because here you can have arterial uptake of radicular arteries, and here you can have a spinal stroke. So that would be your contrast along the lateral epidural space and nerve root sleeve. At cervical level, again, an oblique view, but in this case we're going to look for the facets here, and we're going to advance our needle. We have here the neuroforamen, we have the onciform process anteriorly, neuroforamen, and then facets posteriorly. You have your superior facet, your inferior facet of the level above. You're going to advance that needle down the barrel until you touch the superior facet in the posterior aspect of the neuroforamen. And then we're going to turn to an AP view and just advance inside the neuroforamen lateral to the onciform process. Why we do that? Because when you have that oblique view in the neuroforamen, anteriorly you're going to have your vertebral artery. In the middle, you're going to have your nerve root. And the posterior aspect is going to be free. That's where you're going to have some little fat to advance. And your AP view, those onciform processes are going to be your border for your thecal sac. Anything medial to the onciform process, and you're inside the thecal sac. That's you inject contrast, and you have contrast along the nerve root. You can do this under CTs if you want, or if you want a better idea what's what. Imagine when you're in an oblique view here, anterior is going to be vertebral artery, in the middle, nerve root, and you want your needle here touching the superior facet in the back, and then you slide it in. And when you turn to your AP view, your onciform process here, it's going to be your border for the thecal sac. So you don't want anything medial to that. So this is an injection, and you can see spread along the nerve root there. Yeah.
Do you have a particular landmark on the neck or entry point on the neck where something like this you would go, or?
No, I mean, but you mean at the skin?
Yes, sir.
No, just wherever you get your the view that you need, you just go down the barrel, and you don't have anything there it's gonna be the posterior neck, so you don't have anything that you can touch. Carotids are gonna be somewhere up here. And like I said, very important in your transforaminals to inject contrast. You see here some have vascular uptake, but you can barely see here. This is your vertebral artery. It's going up, it's not going down. So this is the vertebral artery. At this point, you just remove your needle and go back again. Try to reposition that needle at a different point in that neuroforamen. If you inject steroids, if it's particulate, you're going to have a stroke. If it's not particulate, maybe nothing would happen, but also the patient will not have any relief because your steroid will go to the vascular space. Another injection, transforaminal, and you have here a spinal artery. And although very rare, there have been some reports of spinal strokes after ESIs. And last, the caudal approach or lumbosacral approach is going to be the simplest of all three, but also the least effective, because you're going to need a lot of volume to push that steroid up into the level. Like your most common level is going to be L4, L5. So you're going to need a big volume of injectate to reach that level. Patients with extensive laminectomies, you really don't have any other accesses. You can use the caudal approach, and it has the least risk of dural puncture. So this patient had an L4 to S1 laminectomy. Pain was coming from here, bilateral pain. Instead of doing bilateral transforaminals at both levels, which would be 4 injections, we decided to go at the sacral hiatus. So you select in your midline in an AP view, then just go to a lateral view, and you're going to advance your needle until you pop that sacrococcygeal ligament and advance the needle. Remember, your dural sac ends at S2, so you have a lot of space that you can advance that needle without any dural puncture. a P view, lateral view. Inject some contrast. We're there in the epidural space. You can see this is the contrast here inside the sacral canal. And then we do our injectate. So for these epidural steroid injections, our complications very, very, very rare. You have to be very sloppy to have a complication, like a bad complication. You can have infection, like with any interventional technique. You can have an hematoma. That would be the one of the concerning ones. But if you check your coax, you should not have a hematoma. Allergic reaction at the lumbar level. If you puncture the fecal sac, you may have a patient may have a spinal headache after, which is easy to fix. Spinal headaches. Now that I touched that point, same training as doing an epidural steroid injection. Instead of injecting lidocaine and steroid, we take some blood from the patient and inject blood in the epidural space. Any patient that comes here for a myelogram, they come back with a spinal headache. We use a translaminar approach, like we're doing an ESI, same setup. Use the loss of resistance technique, get into the epidural space, and then just draw 20 cc's of blood from the patient and immediately inject it in the epidural space, and that's it. Patients get better real fast. And very, very rarely para quadriplegia. Like I said, you need to not be careful doing what you're doing and miss a anterior spinal artery or a vertebral artery, something like that, and inject. And on top of that, you need to be using particulate steroid. Like in this case, in the lumbar, like I said, at the lumbar level, even if you have a thecal puncture, it doesn't matter. The patient may not get a spinal headache. You can see the needle here. This needle was in the midline, so if it's all the way to the anterior, touching the disc here, that means it went through the thecal sac and to the anterior space. If that happens, say you miss that loss of resistance and you keep going until you touch some bone, then you turn to your lateral, and your needle is all the way ventrally doing a discogram. Then just remove the needle and that's it. Patient may or may not get a spinal headache. I mean, there's nothing to puncture there. It's not the same for the cervical injections. Midline, needle is again at the ventral level, but if you're at the cervical level, then you went through the spinal cord. These people, I don't know. I mean, at this point, you could just remove your needle and maybe the patient does well. Probably they didn't look at the lateral. That's why I always look at the lateral at the cervical level. I don't do it at the lumbar level, but I do it at the cervical level. They injected contrast, and that's contrast inside, like dissecting the spinal cord. I want to assume they didn't look at the lateral because there was no way you could inject contrast if you know your needle is like all the way ventrally, because there's no other structure there but spinal cord. And patient had, of course, a big stroke. Is one of those cases that patient is paraplegic after an ESI, one of those case reports in the literature. You may hear that you get 3 injections and you get better. Well, that's not true. We usually don't do more than 4 in 6 months, and that's just because the steroid, accumulation of the steroid. If the first injection does not help the patient, there's no point of doing another injection at the same level. We may try a different level, but not the same level. And we do not repeat them before 7 days. How many do we do? Depends on the improvement of the pain, functional improvement, if the patient decreases the use of analgesics, and how much is the effect lasting. Facet blocks. Different type of pain, not radicular pain. This is mechanical pain. It's usually going to be located above the buttocks. You're going to have a painful point that's above the facets, It has a primary area of radiation, a secondary area of radiation along the back of the leg. Commonly bilateral, up to 40% of the lumbar pain and 50% of the cervical pain is going to be due to facet block. Facet pain. We can do direct blocks. That means we put our needle inside the joint, or we can do indirect blocks. That means we numb the nerve roots that are innervating the facets, and that's the medial branch block. The medial branch is a nerve that is going to innervate our facets. It's going to allow physical therapy, and if we want to do definitive treatment, then we need to do radiofrequency of the medial branch, which has a 70% improvement rate for facet pain. Lumbar level, and you're going to see this throughout the talk. For the lumbar level axis, all of them is in a oblique view, Scottish dog view, same view as your transforaminal. But in this case, our down the barrel view is going to be targeting the facet joint here. We inject contrast and we see that spread of contrast along the facet. Remember, that's in an AP view inside the joint capsule. Remember, we have articular cartilage in that joint, so we don't want to put our needle right in the middle of that joint. We don't want to damage that cartilage. But we have some superior and inferior capsular recesses that we can use to put our needle in, so that's where we target our needle, above or below the capsule. If we want to do an indirect branch block, again we inject 0.1 cc of lidocaine and steroid inside the joint for a therapeutic facet block. If it's just diagnostic, we just inject lidocaine. Medial branch block, the medial branch goes below the mammilloaccessory ligament, and it's going to innervate the facet below and the facet above. So if we want to block, let's say L3, L4 facet here, we need to do 2 injections. We need to block the L4 medial branch and the L3 medial branch. And at this point, to do this, we don't use steroid because it's not going to do anything. We just use lidocaine. We want to see if that facet is really the one causing the pain. So we block those 2 nerves. If the pain goes away, then we can do radiofrequency ablation of those 2 nerves, and the patient may get better. We're going to target the superior border of the eye of the Scottish dog right here. So inferior for transforaminal epidural steroid injection, superior for medial branch block. We touch that. We touch the bone. We turn to an AP view, and we want to see our needle in that little nook between the superior facet and the transverse process. That's where the needle's going to be. We inject a little bit of contrast. We just want to have the contrast spread right there. And then we inject lidocaine 1%. Patient goes home and tells us if the patient went away, if the pain went away. This is where you have that medial branch. If you see, the medial branch will innervate superior facet, inferior facet, and the next one will have superior facet, inferior facet. So to block this facet, saying this, let's assume this is L3, L4. So this facet, we need to block medial branch above and the medial branch below to be able to block this. At the cervical level, if we're going to do it directly, we just go in a lateral view. We're going to have our lateral masses, our facets here, and just down the barrel inside the articular space. like that. Inject contrast. We see the contrast spreading inside the capsule, and then inject a lidocaine steroid of our choice. If we're going to do the medial branch block, then we're going to go to the center of the. This is a representation of a study that showed cadaver study that looked at 10 cadavers where that medial branch block went. So if you see, most of the time it's going to be in the center of the lateral masses. A C3 is going to be a little above, C4 almost at the center, C5 center, and C7 above the center of the lateral masses. So again, in a lateral view, now we're going to target down the barrel until we touch the bone at the center of the lateral mass, change to an AP view, and we're going to want our contrast right there, lateral to the facets. It will be right here, and that's where our medial branch blocks goes, right in the center of our facets. Sacroiliac blocks, again, mechanical pain. This is going to be usually unilateral at the buttock. Our pain is below L5, 1 to 50% of all patients with back pain, and it's going to be worse when the patient has unilateral load. We can do diagnostic if we only inject lidocaine, or therapeutic if we add a steroid. Remember that most 2/3 of your sacroiliac joint are going to be just fibers, and just the bottom third is going to be articular. So the bottom third is the one that has a capsule. So that's what we want to, where we want our needle to go. We're going to use an ipsilateral oblique to look at that. Try to just find that radiolucent line that is going to tell us that the bottom third of the sacroiliac joint is in line. So you're looking at it all the way through. Advance that needle to that bottom third, inject contrast, and we're going to see it spread. You see here, spread inside the joint. C1, C2 blocks, degenerative changes of C1, C2, C2, C3, and atlanto-occipital joint will cause our common causes of headache, occipital headaches, and you can see here the radiation pattern of all those articulations. If we're going to do C1, C2 block, this is a open mouth view. We're going to target the lateral, the joint of the lateral third with the medial third. And that is because the lateral third, you're going to have your vertebral artery, and the medial third, you're going to have the thecal sac and the dorsal ganglion root. So the middle third is the one that is free and that we can target with our needle right here. Remember, the patient is prone, so, and you are not in the midline. So this needle looks like it's going through that canal, but you're not in the midline. So that's why you want to be in that middle third. You have that needle there, inject contrast, see that pattern, and inject our lidocaine and steroid. That's the capsular pattern of C1, C2. Now, all these techniques that I talked about are the ones that we usually use for the patients between 0 to 8 weeks or 8 weeks to 6 months. After 6 months, we can offer neurostimulation. Is something you can do too. You can see here in the pyramid of management, we have NSAIDs, interventional techniques, then surgery, then neurostimulation, long-term opioids, etc. You don't need any special training. If you do epidural steroid injections, you can do neurostimulation. It's the same translaminar epidural access with the syringe and the needle. We're going to put some leads that are going to have some electrical impulses just to the posterior columns, and they're going to inhibit those pain signals before they reach the brain, okay? And it's indicated in the management of uncontrollable pain more than 6 months, okay? It's an effective pain control method. It's going to reduce the need for medication, less invasive than any other surgical option at this point with a patient that has pain for more than 6 months. It's a reprogrammable system. It has a battery, and it has a wireless system that can be used to dial that electrical impulses up or down. And we can do a trial before permanent implantation to see if the patient gets better or not. If it doesn't get better with the trial, then that's it. They don't need to go to the surgery. What are the patients that are good for this? Fail oral opioids, fail conservative interventions, fail pain correlates with pathology, fail surgery. There's no other surgery that the patient can have. There's no history of drug abuse. There's a psychological evaluation. Very important to have that before we accept the patient, and that there is no contraindications to the implant. Studies with neurostimulation show, like in patients with chronic pain, they showed a 47% improvement versus patients that went for reoperation, with a 12% improvement in the patient that went for reoperation, resurgery. The electrode placement is a 2E needle, an epidural needle, the same we use for ESI. We access the epidural space with the same technique, and then you can inject contrast, see that you're in the epidural space, and then we just thread that lead, navigate it into the posterior epidural space up to the level of T9, T10. You can see here, this is the part of the lead that has the electrical impulses. Why T9, T10? Because remember your spinal cord, your somites, that's the level where you're going to have most of your cauda equina neurons at T9, T10. As you go down, they compact, and you have L4-5, L5-S1 is going to be at T9, T10, your neurons there. Patient, this is for the trial. You put the electrodes in, electrodes come out, you put a patch there. Those electrodes are connected to an external battery, and the patient goes home with that battery for a week, and then we have them come back and see if they got better or didn't get better. If they did get better, then we can internalize those leads, and we can use a small pocket battery and make it a permanent implant. Or there's a second option if you're working with a surgeon. That's the surgical implantation. You take these leads out, and then they do a small laminectomy, put some paddles. The thing with the paddles is, if you see here, this is just like a small catheter. The paddles are paddles, so they have a wider area of influence with the electrical impulses. So at least here they prefer to do that. They put the paddles in, and then the paddles come out the same way. You internalize the leads, and you put the battery here next to the hip of the patient. New batteries are MRI compatible, so patients can have MRIs. All batteries are not MRI compatible, so the patient cannot have MRIs. The other advantage of this is, if patient does not have any relief, or it has relief for 6 weeks, 6 months, a year, and then it stops working, you can take all this out, and the patient is left with nothing in.
Can you go back?
Mm-hmm.
Was that your artwork that you did at the same time? Your artwork?
What artwork? Oh, that was already there.
You probably would get paid more for that artwork.
To do that, yeah, probably. And then the patients, they complain of patients that you see with tattoos. They complain more of pain when you put the needle in, and they have these big tattoos, and you're like, oh, man, how come you got this? And you're complaining of a small needle. Well, pain management, they're very simple techniques. You can learn this in a week or a couple days, as long as you know your regional anatomy. And that's why I think, although this is not being done by radiologists in a lot of places, I think we have the better understanding of the anatomy. I mean, you train looking at all these fluoroscopy images or X-ray images, so you know what is what, and you know where to put your needle. And as long as you know that anatomy, what goes where, what's coming through there, you should be fine. For your lumbar accesses, everything is the Scottish dog view. You're gonna have, if you want to access the disc for a discography, same view, just put the needle there in your disc and it'll go through the disc. Then you switch to an AP view and advance the needle into the disc. Medial branch block, superior border of the eye, transforaminal epidural, inferior border of the eye of the Scottish dog, and your facet block just directly into your joint right here. For lateral, you need a couple other views. So you're going to have discography is done in an AP view. We push the discography or kyphoplasty. You push the trachea away, and you go in between the trachea and the carotid. Advance your needle to the anterolateral part of the disc, and then just push the needle in a lateral view. So discography is an AP view. Medial branch block and facet blocks are going to be in a lateral view, down the barrel. Medial branch block at the middle of the facet, and facet block just in your articular space. And the nerve root block in an oblique view, ipsilateral oblique, in the back of the neuroforamen. We always try to plan what we're going to do, so we're not doing one injection in another level and another level. We have to know our anatomy, so we have to be careful. And I didn't touch this point, but we have to work safe. Our hands have to be outside the field of view. Remember, all the new equipments have automatic exposure, so even if you have leather gloves, you put your hands in, that's just going to up the exposure and you're getting the same radiation. I don't use leg gloves, but I try not to put my hand in there. Thank you. Questions? Yeah.
¿Cómo se dice?
The switch. Yeah.
Why do you think?
I mean, there's.
Because the reason is there are so many options,
Mhm.
and back pain is so common.
The problem is we don't have an answer for that. I mean, patients come because pain is something subjective, and you try to figure out if the patient really has pain or not. With the MRIs, you know, a lot of patients have normal MRIs.
Why does the patient have pain? What is the cause of the back pain?
Well, the inflammatory response. If you have a disc,
But before the inflammatory response,
Mhm.
someone like you or me,
Mhm.
why do we have back pain?
oh, that comes from our position, from our standing position. Yes. Yes. Mm-hmm. Misalignment when we're sitting down, when we're working, where we're the load that the lower back pain has.
What are your thoughts about, for instance, exercise, losing weight, and yoga, and all this stuff?
That works every time. There are a lot of patients that come with back pain. They're overweight, and if they lose 40 pounds, their back pain goes away. The problem is that's hard, and it's hard for the patient to do. And I've seen it firsthand in my family. My father had one of these done. He was overweight. He lost 40 pounds. pain went away, he didn't need surgery. He gained weight back, pain came back, and then he had to go to surgery. So the weight is has a lot to do with this. Mm-hmm.
What I want to say is that this is kind of philosophy that in current medicine, sometimes we try to fix a functional issue that occurs with fragmentation and trying to silence what complains. But the complaint is, I think a change of lifestyle can really help.
I mean, for a lot.
This is probably the most common cause. When all this, the ligaments are not able to maintain a line properly, the patient has pain. And has the arrangement of the joints and everything. And overweight is another issue. I think that going to the cause of the back pain is, I think it would be the idea of treatment, and also it's not so expensive, it doesn't have pain and everything. Look at that nice lady with the tattoo in her back. How nice it is to have these wires hanging from her body. What kind of lifestyle? You're going to kind of go to the pool with that. So, but what I'm telling you is that we're really in the millennium, we physicians need to be thinking proactively. If we know the cause, we need to go to the cause, not to the organ that is suffering for that cause. What I'm saying is something I would like you to be thinking about, because skilled people like Dr. Cuellar can do wonderful things, and I think you have shown the technique, thank you, because it refreshes a lot of things. But the point is the patient will come back, will be a chronic customer. It's like the people that take Epidural and high cholesterol and don't change their diet. The same thing. I think we need to think really to what the cost and correct the cost, and that probably will be a better medicine for all.
The poor patient, the healthy foods cost more money. The cheaper, that's why if you go to buffets, there are a lot of poor families, that's what they eat. They eat McDonald's because if you get $1 a cheeseburger, they go to the pizza buffets because they can fill up for the whole day, and it's cheaper, and they can't afford healthier food, and that's sad. And that's, for pediatrics, obesity is a horrible thing. Because there are some, fat children.
And exercise, I mean, all those same families don't have time to take kids to, yeah, exactly.
We didn't have that growing up. We had to go outside and play.